Ryan White was a teenager with hemophilia who contracted HIV from a blood transfusion in the 1980s. He was expelled from middle school because parents were terrified he would infect their kids. He fought back in court. Ryan was white, young, and articulate. He became the innocent victim that allowed politicians to talk about AIDS without talking about gay sex or drug use. It was a cynical political distinction, but it worked. When he died in 1990, Congress passed the Ryan White Comprehensive AIDS Resources Emergency CARE Act. The act is a payer of last resort. It fills the gaps. If you have HIV and no insurance, Ryan White pays. If you have insurance but can't afford the copays, Ryan White pays. It is categorical funding, money earmarked for one specific disease. This is controversial. Why do we have a special system for HIV but not for cancer or diabetes? The answer is political power and the unique stigma of the disease. The act is divided into parts. Part A goes directly to cities, EMAs hit hard by the epidemic. Part B goes to states. The most revolutionary part of the act is the planning councils. In each city, a local council decides how to spend the millions of dollars. The law mandates that 33% of the council members must be unaligned consumers, people living with HIV who do not work for a funded agency. This codified the principle of nothing about us without us. It gave the patients veto power over the doctors and bureaucrats. It turned the patients into policymakers. It is a model of participatory democracy that we rarely see elsewhere. How do they evaluate success? They moved beyond simple head counts. We saw 1,000 patients to the HIV care continuum or cascade. They measure every step. How many are diagnosed? How many are linked to care? How many are retained in care? How many are virally suppressed? This allows them to see exactly where the system is failing. If we are diagnosing people but losing them before they get meds, we need to fund case managers, not more pills. This data-driven approach allowed them to target resources with surgical precision. The HIV/AIDS Bureau, HAB, established strict performance measures. Agencies have to report data on viral loads, syphilis screening, and housing stability. If an agency fails to meet the standards, they lose funding. This created a culture of continuous quality improvement. It shifted the nonprofit mindset from "we mean well" to "we have data." It proved that you can have rigorous accountability in a social welfare program. Because they had such good data, they could see the disparities. They realized that while white gay men were doing well, black women and young MSM, men who have sex with men, of color were falling out of care. They used the planning councils to reallocate money specifically to those populations. They funded peer navigators and transportation vans. They treated equity not as a buzzword, but as a hard metric. If the viral suppression rate for black men was lower than for white men, the program was failing. Period. There is a tension. Congress mandated the 75/25 rule. 75% of funds must go to core medical services, doctors, drugs, and only 25% to support services, food, housing, ride shares. The community hated this. They argued that housing is health care. You can't take your pills if you are homeless. They argued that the strict medicalization of the funds ignored the social determinants of health. This is the classic micro-macro conflict again. Congress wants to buy drugs. The community wants to buy stability. Despite the tension, it worked. Ryan White clients have higher viral suppression rates than HIV patients with private insurance. Why? Because private insurance gives you a plastic card. Ryan White gives you a case manager who calls you when you miss an appointment and a van that picks you up. The wraparound model works. The question is, why don't we do this for everyone? Why isn't there a Ryan White for diabetes or opioids? The answer is cost and political will, but the blueprint exists. To conclude, Lesson 3, the Ryan White Care Act proves that the government can run a highly efficient, high-quality healthcare system for the poor if it listens to the patients and tracks the data. It sets a standard for what program evaluation should look like. In the next lesson, we are going to look forward. We will discuss the future of bioethics, artificial intelligence, global health, and the looming threats that our current laws aren't ready for. Peter Drucker said, "What gets measured gets managed." But we must always ask, are we measuring what matters, or just what is easy to count? See you in Lesson 4.